Good evening, ladies and gentlemen. My name's Peter Joyce. For those who don't know me, I'm Dean at University of Otago Christchurch, and it's my pleasure to chair these public lectures. This is the third in a series of 6 for this year, and tonight's lecture has been given by one of our senior professors, Professor Steve Chambers, who's in the Department of Pathology. He's had a joint appointment with the DHB for many, many years now, and for a long time he was head of infectious diseases for the Canterbury District Health Board. So tonight he's going to talk about Ebola 1 year on, and without more ado, hand over to Steve.
Thank you, Peter. Well, thank you for coming along this evening. It's really nice to see you here, and I've prepared some material here for you, and I'm not altogether sure of the level of knowledge we have, so I'll keep it pretty simple. So, and then at the end, if you want some clarity about things, I'm very happy to take some questions. So, just what we intend to do, a description of the epidemic and where it's got to, a bit of history about Ebola, and commenting on the fact that well-known control measures will work well if implemented effectively. Comment on the international efforts which have been far too slow. I'll give you a clinical description of Ebola and its management, and the importance of the local culture and sensibilities in putting in a relevant infection control program. Discuss briefly the impact on medical and nursing staff, and comment briefly on the development of vaccines and treatments, and give an idea of the roadmap that's ahead as put out by WHO. So, what about the current situation? I think everyone knows who's read the newspapers or looked at the news that this epidemic began in West Africa in December of 2013. There was a young 2-year-old boy, Emil, who became unwell in his village. Other people helped look after him, and then it spread very rapidly to capital cities. And this was unseen before in Ebola. And from there, it spread to other urban areas across the borders into neighbouring countries. But very early on, Médecins Sans Frontières was notified, and they started to raise the alerts. But it was 3 months and 1,000 deaths later that WHO declared an outbreak. And it was really 5 months until the global humanitarian response kicked into gear. This is a photograph of Emil, first victim. You can see the little babe in arms there. And there's his dad is holding him just in behind. And I think all those people are dead. Here's a little plan of what happened in terms of the transmission. You can see Emil there at the top, and his sister Philomene, and his parents. They were attended by a nurse at the Adadevoh hospital, and then spread occurred within the hospital. It then went out to other villages, and you can see it I'm not sure I can show it here. Maybe I could have a pointer, I don't know, Peter, because this is the point. You can see it spread out into the other villages where many more people got infected. It spread amongst the healthcare workers in the hospital, and then out into another doctor, and then the doctor and all his brothers got it, almost all of whom died. So it's a very rapid spread which is occurring, and you see the time frame down the right-hand side there. This is a composite map of how it was spread, and if you can see there right in the middle of this confluence of 3 countries, Guinea, Sierra Leone and Liberia, is where this started. And then the months are going across the right. You can see March there, and then April. You can see gradually it's becoming redder, and more districts are being involved, more countries being involved. And then as you get, and you can see where the capital cities are. So in the bottom left-hand corner there, you can see Freetown, which is the capital of Sierra Leone, and Monrovia, capital of Liberia. And if you just keep your eye on Monrovia there as you go across, you can see very intense transmission occurring within the urban areas. So you've got this multifocal urban-rural spread with very intense transmission occurring in these very poor towns. This is a graph of the incidents occurring over time. And And you see the three countries there, Guinea, Liberia and Sierra Leone. And if you look at the middle one, Liberia, this is a country, this is a classical picture of an outbreak which is occurring. When there's a point outbreak, it occurs, there's an epidemic, and it goes up and goes down. It's even got a name, which is Farr's Law, describing that. If you look on the right in Sierra Leone, you'll see that there's the epidemic curve looks a bit the same. But you look across the left, where it started in Guinea, and you see that there's a sort of a stuttering start, and then the shape of that curve is looking quite different, which makes you very suspicious that actually things aren't all well there, that the description of the epidemic isn't right, and that it's likely that the control measures aren't, and the reporting isn't accurate. This is a summary of the cases that have occurred, just so you get a bit of a sense of it. You can see the number of cases in bold there in Guinea. 3,000 cases with 2,000 deaths, which is roughly a 60% mortality rate. Liberia, on the other hand, has got 9,000 cases with a somewhat lower mortality rate, and then Sierra Leone at the bottom there, 11,000 cases, and they've got a much substantially lower mortality. Again, the differences in the epidemiology and the description makes you concerned about there's been either over-reporting, under-reporting, and the lack of hard information based on good diagnostic techniques. So you may get the number of cases rather skewed. Of course, when it happened in Africa, there was then spread out to the Western world. And you can see there the countries that were involved. The United States, obviously, we all heard about what was going on over there. UK, Norway, and other places, in Spain. Now, if you look down at those bars at the bottom, the green, you can see the mortality and the number of cases and those managed in the West. And there the mortality, I think there's 5 deaths out of 24 or something like that. So the mortality is more like, 25% or something like that. So the mortality rate is substantially lower. And of course this creates this issue about, how do you manage this awful disease in resource poor settings, and what resources are available for its management in places that have lots of resources. So if you're lucky enough to be born in the United States, President Obama sort of sends over a plane and you get put into the thing there and flown back. This is actually the hospital room in Nebraska where the first patient was managed in the United States. And obviously this is a completely different kettle of fish. And with all the benefits of modern medicine, we're able to, mortality was so substantially lower. The public health response is also quite different. So this is just the public health response for that one case that went to the United Kingdom. You see one case, there's a healthcare worker. There were 55 patients who were contacts, all of whom were followed up. And that follow-up of cases, so you followed the infection trail to the end, is really important. So what's not happening, obviously in Africa, is identification of the contacts, managing to isolate them and look after them. So what about the history of Ebola? It was first diagnosed in 1976, happened to be the year I graduated from medical school, and was found in a small mission hospital in Zaire. And news sort of spread that this event had occurred, and Dr. XS, I've called him because I don't know what his name is, an African doctor, a man of actually a lot of courage, was sent there by the government with soap and water and some specimen containers to go and see what was going on. And when he arrived there, people heard that the doctor had come, and so they sort of emerged out of the bush to see what was going on. He looked around and found that there were quite a lot of bodies, and there were only 3 nurses there, all from a Catholic mission. One of them had died the next day, and all 3 of them died. And there were a lot of bodies around. People came to see what was happening, and gradually he collected samples and he sent those off to Belgium. Now remember, Zaire was previously the Belgian Congo, and so there's links with the Belgian Congo. So Peter Piot got these samples in the Institute of Tropical Medicine in Belgium, Antwerp. And what he got was a thermos flask, and in it he opened it up, and here's this blood swilling around inside and lots of broken vials. Now, bearing in mind these came from samples where there's a mortality of something like 90% in this outbreak, he was obviously understandably just a little bit nervous about how he handled them. And so he does electron microscopy and showed there's a virus that had never been described before. This is the gentleman here on the right, Peter Piot, that's in his institute. And the virus which he saw down his electron microscope is this filovirus, which is like a thread. And you can see it's a long skinny thing, and it's nothing like that had ever been seen before. There's a cartoon at the bottom right there which gives an idea of the structure. You can see it's a long thread. Inside there's a single strand of RNA, which is obviously the genetic element. And on the outside there's a viral envelope or membrane. Now that membrane is derived from the host cells. And the important thing about that is it means that it's easily disrupted with things like detergents and soap and water. So the soap and water that brave doctor took with him was very important for the infection control elements. Obviously there's other proteins on the outside which are derived from the virus itself, and you can see the little sort of bits on the outside, and they're important because they're the antigens on the surface which are specific to the virus and can be targeted with antibodies and so on. Now, the top left picture there is a picture of the Ebola River. So if you want to know where Ebola name came from, it's because this village was right next to the Ebola River. It just looks like pretty nondescript sort of river, really. No doubt plenty of bats in the trees. And you can see on the right there, this is the plane he landed in. The usual thing if you manage to fly into an area like this is that the pilot wouldn't let stop the engines, he'd keep them roaring and usually take off when half the stuff had been taken out. Pardon me. And you can see one of the nurses he took with him into the hospital. This is actually where the initial outbreak took place. And here he is, dressed up in his kit here to stop him getting infected. This is just a photograph of his workbook and the map he drew. Now these are absolutely core things that you do for basic epidemiology, good old time and place and person, what's happening where. It's written in French and it's kind of interesting to try and decipher it. But you can see here the map of the village which he did. So he was trying to figure out where it was that the virus had been, how it was spread, and what was sort of stopped the epidemic occurring. So just a bit about that outbreak. 280 people out of 380 died. There's 88% mortality. There were some survivors, and because he was able to interview them, he found two key things. One, most had been at the hospital, and secondly, many of them had been at funerals. And both of those are critical, obviously, for the transmission of this bug. And of the young women aged 20 to 30, they'd all attended antenatal facilities at the hospital, at the clinic. He also found that the village only had 3 syringes, and that they'd been used for multiple injections. And I must say, in 1976, no one knew about hepatitis B or HIV or so on. So I think this is relatively common practice. Pardon me. Now, if anyone's interested in just basic epidemiology and how it developed, there's a book called The Ghost Map, and some of you may have read it. I haven't read it, but when I first went to the London School of Hygiene and Tropical Medicine, the first lecture was given by the dean of the school, and he told the story of John Snow. John Snow was the physician in London who was present at these terrifying outbreaks of cholera with very high mortality. And he and the local vicar, Henry Whiteside, I think, they mapped out what happened, and they showed that all these cases were occurring within walking distance of a pump that pumped water in Broad Street, and it became very famous as the Broad Street pump. The stench of all the poo in the street and what was round about made people believe that the miasma, or what was in the air, was transmitting the bug. Everyone knew that was right, except they had the clue that maybe it was waterborne. And indeed, when he mapped it out, he found that there was a woman who lived up in Hampstead who previously lived nearby, and she sent her servant every day down to get water from that pump, and she was the only one who was able to drink it, and she's the only one that got cholera and died. And so gradually the evidence came that it was water that was spreading it, and he took the handle off the pump at Broad Street and the epidemic went away. There's a lot more work done, but if anyone is interested, the basic sort of shoe leather epidemiology of, you know, what's happened when and where and what are the links is still really important for controlling outbreaks. So what about subsequent outbreaks? So before the current epidemic, there's been something like, I think it's 28 outbreaks. And the numbers of these range from one, where just an isolated case, through to many. The mean is just sort of something like 85. Mortality rates were something that ranged between 25 and 90%. Most in remote forested areas. You can see that photograph of the river. You can see how sort of remote and the geography contains the thing. Pardon me. But all of them have been contained just by the simple basic things: early diagnosis, contact tracing, isolation, burying the dead safely, and standard infection control, soap and water and chlorine, which disrupts that membrane around the virus, and have been delivered through local healthcare systems with a bit of support from international partners. So just looking at this, where these outbreaks have occurred, so this is 5 strains or so, and you can see in the West African area, that's where this Zarian strain's got to, but there's been lots of other outbreaks. And you notice in particular over here in more East Africa and around Uganda and Kenya, they're around Lake Victoria, and actually the samples that Peter Pio took at that time were very important for the epidemiology of HIV, because all those samples were re-examined later and found that that was the epicentre of the HIV epidemic. Now, we've known a lot about this for some time. These are posters that I downloaded from the CDC, which go back from way before when this happened. And you can see the basic facts. Pardon me. You can't get Ebola breathing through the air. You can't get it through drinking water. You can't get it through food. You get it through body fluid exposure from people who've died of Ebola, anything really that contaminates them. You can get it through sticking yourself with a needle or other device, and you can infected animals. Now remember, primates also get this, and so there's been a lot of deaths of chimps and also other great apes from Ebola. And often these animals are used for bushmeat and so on. And what should you do when you get it? It's only spread when people are sick. Patient must have symptoms, and after 21 days you'll know whether you've got it or not, because that's when the incubation period is. Why does it cause such severe disease? Well, this virus infects macrophages and dendritic cells. Now, these are 2 key cells in the immune system. The macrophage is one that produces a whole lot of cytokines which promote the inflammatory response, and they live primarily in the bone marrow and the lymph nodes, but also the liver and spleen, which take a big hit when these cells are killed. And also in the dendritic cell. Dendritic cell is a cell which picks up viral particles and other things and then goes and takes them to the lymph node and says to the immune system, here, go find this and kill it. Now you can imagine if those cells have been taken out and killed before that, it stunts the immune response. And it leads to this huge inflammatory reaction, which will cause little clots in the blood vessels and further impairing organ function and stops the development of antibodies. So it tends to be immunosuppressive in its own right. Okay, so why the delays? 2 months and 1,000 deaths before WHO declared an international emergency. Another 2 months before global humanitarian response. I think the key here is just the unpreparedness. In other parts of Africa this had been seen, it had never been seen in West Africa. They had a very fragile health system, incapable of responding. The people in the rural areas probably move less and take it with them less than people in the cities. And once it spread to the cities, you saw that intense transmission occurring in the urban areas. At the same time, there's a separate outbreak in the Democratic Republic of Congo, and that was contained and declared Ebola-free within a few weeks, compared with this, which is ongoing. Now, one of the key things that's essential for control of this is engaging with the public. Now, we all work in several paradigms. In the medical world, we do a lot of analysing and thinking, and then think about what we're going to do, make a plan and try and put it in place. Other part of us works in a much more human thing, which is to see things going wrong and then to feel it and then act and change. From the public's point of view, I think they operate much more in the seeing what's happened, feeling the angst of it, and thinking about what change can be put in place. And that may take a bit of time. And the doctors, they sometimes get a bit frustrated about what they think should happen. But the emotional content of what happens is very important for an effective response. Now, this is a brilliant success in Nigeria, which I will just comment on, which is really the cerebral response. This lady here was the one who's credited for stopping the spread in Nigeria. Her name is Dr. Adadevoh. She was on duty and a patient came in called Patrick Sawyer. He was a Liberian American, and he came to Lagos Hotel and he was unwell. He denied any contact with Ebola, which was untrue, but she thought perhaps that was the case. The patient had to be physically restrained by her and 3 of her colleagues to stop them leaving. The Liberian government then got in touch with the Nigerian government and insisted that he got released to go to some conference. She refused. She insisted that there was a public health alert put out and an institution of proper infection control. They traced over 1,000 contacts. An extensive media campaign was launched within a few days, and if you went into Nigeria, you saw billboards everywhere. Everyone knew about Ebola within a few days, and it was stopped with 20 cases and 8 deaths. And of course, she was one of the victims. She and the 2 other doctors who restrained the patient were exposed. She was an extraordinary woman, actually, and her dad was the professor of pathology at Lagos University. Her grandfather, he was the vice-chancellor of the university, and her great-grandfather was the bishop of Nigeria. And she obviously had an intense public health and public-spirited motivation. So, key strategies. Safe burial, quick, dignified burial is essential. And of course, the staff who are going to do that, the people who've been recruited to do that task, are stuck in very hot stuff. They're very slow and careful what they do. They have to be hosed down with disinfectant and so on in their suits. They obviously smell bad as well as looking threatening. You need to get the basic epidemiology right, find the patients, many of whom are unknown, and often the only ways of finding out who they are is to go to the funerals and try and figure out who has been in contact at the funeral. And then you've got to isolate the contacts. Now, people don't want to be isolated. That's obviously disruptive to them, and their work gets impaired and all the rest of it. The funeral practices are very important. In West Africa, both men's and women's have separate initiation societies, and they also control the deaths and the funeral practices. So these are gender specific, so sort of minimum information is that the women would braid the hair of the woman concerned and dress her up nicely, and the men would be shaved. Obviously a sharp instrument and so on was pretty important. So you can imagine that just a little bit of breakdown in infection control, just that exposure is going to create many victims. And one woman has had at least 375 people infected from her funeral, almost all of whom died. So, a safe burial is absolutely crucial, and it's very disruptive for a society when they're not able to grieve in the way they deem as appropriate. And not only that, in this society, you know, these are areas where there's a lot of issues around slavery and history, and around HIV trials, which didn't necessarily benefit the local people and so on. And so there's a lot of local suspicion, not surprisingly. And so the trust and communication were pretty jolly minimal. Here's some photographs just taken from the web. Now, if you get HIV and you get desperately sick, a lot of people will make their way towards a healthcare centre or elsewhere, and they will die just sort of where they are. Many people are found actually crouched in the doorway. They look as though they're praying or whatever, and they're dead by the time someone comes to look. This is just a photograph taken by one of the BBC journalists. And of course, the people are looking to see what's going to happen. And what happens is that these sorts of folks arrive, the burial team. And you can see they look pretty frightening, really. They're covered in, some of these are covered in this stuff. These are brave people, I must say. And sometimes they look like that, where the body comes and gets taken away, and they'll be buried very quickly, essentially saying, God bless you, rest in peace, and a hole in the ground. And you see, that's terribly disruptive to the whole grieving process of the nation. The people who do this task are also in a bit of bother. Most of them don't go to work they go to work before dawn, so they get up and they stay away until it's dark and then come back and go to sleep, because the neighbours are very worried they're going to bring it, and the next thing they're going to be infected as well. And you can see the kind of stony looks on these people's faces, and you can imagine that they may be pretty suspicious about what's going on. Some people survive, and of course the net result of that is that there's tremendous social dislocation occurring. Many times there are whole sort of streets that have got no one there, and the only record you have of the person living there at all is this is the National Election Commission's, and that's the photograph of the person, and that's the only record of their existence. And outside, civil society disrupted because there's checkpoints. You can see this chap here's taking the temperature of this guy, and you can see that he's got his face mask around his throat, which is around his neck, which is probably not doing much good. I think the policeman might be holding his in his hand there as he's sort of directing people. So engaging with the public, that emotional response, trying to get people to understand that honestly your lives and your society depend on you changing has been the task. And how do you do it? Now, after some time, a lot of the politicians engaged in this, in particular the president of one of the countries, and I've forgotten which, I'm sorry, did a tour with a musician. And everyone realised that this was for real. The minister concerned of gender, social welfare and gender issues was a musician. So he made 8 songs, and these things got played on the radio quite a bit. So, you know, you control the media, you can play the stuff, but it started to get right through the whole society. And they developed their own little dramas and go door to door and educate people and so on, mainly about prevention, use of soap and water, and avoiding body contact. So ABC in the HIV world is abstinence, be faithful, or use a condom. They had their new one, which is avoid body contact, which was the new sort of public health thing. And here's just an image of some of the radio things that were going on. Okay, so what about the clinical features? Well, it starts off with a febrile illness, with aches and pains in the body and fatigue. Then there's this gastrointestinal phase, which lasts 3 to 10 days, which you carry on obviously having the fevers and so on, and then you get this epigastric pain, tummy pain, nausea and vomiting and diarrhea. If you survive through that, then you either go into renal failure or you recover, and the renal failure is associated with low blood pressure and so on, difficulty breathing. But the diarrhea starts to get better, and you may be able to eat and drink a bit. So you can see that the major complication of dehydration is really, really severe. And then after that, there's sometimes this bleeding from the gut, and there's confusion, pardon me, and there seems to be a significant phenomenon of confusion and so on. And then your skin may slough and hair drop off. Now, there's been 1 or 2 very good studies done, and this is just a wee bit of detail from one well-performed study. And you can see here that amongst the patients, most are quite young, 15 to 44. The case fatality rate in this study was 71%, and I think this is well-documented data. Incubation period, 11 days or so. The PCR, which is a way of testing for the virus particles in the blood, becomes positive within 24 hours, which is an important thing, but you can still get negatives up to 72 hours, and that's really important when you're trying to figure out how you're going to manage the patient. And the key things is this vomiting and large amounts of diarrhea, and you can see often 5 litres a day, persisting up for 7 days. Respiratory symptoms are rare. So early on, once you start to get a few cases occurring, the healthcare system was completely overwhelmed. When people went to the hospital, they didn't expect to see all this stuff covering them over, so this led to this poor interaction between the patient and the doctors. And many doctors then would start to not use the equipment because they couldn't react to the patient properly, which obviously led to a high mortality in the medical staff. There's a triaging system, and I'll show you a diagram in a minute how this sort of works, but chlorine spray was the key thing to try and stop spread. And obviously a lot of equipment and things was lacking. You still have this issue of, well, how do we differentiate this from malaria and typhoid and other infectious illnesses? So that's where these tests come in. But often that test, the Ebola, takes time, and you may have to do it again to be absolutely certain. In the meantime, the patients are treated with things to stop them vomiting, and then fluids and so on, trying to control the vomiting and diarrhea. And because the survival rate was so low, you can see that a lot of people thought, oh, I'm not going to hospital before I'm going to die if I go there. So the issue of building public confidence is essential, and you've got to have some successes, otherwise patients are not going to come along. So this is a map, again, taken from data, the thing that happened from Médecins Sans Frontières long before this outbreak occurred. But you can see here how a triage system might work. So patients sort of come in, you can see at the bottom there, patients have one way getting in, the staff another. And these blue things are buckets of chlorine, which are supposed to be used for washing hands and everything else that goes on, and for spraying. Patients with probable suspected cases on the right there, and you can see they've got their own latrine or bathroom, everyone's got that. The patients who are in the high risk zone for confirmed cases at the top there. And then, you're trying to get, not have to get the patients who have clearly got it, and you're not going to spread it to others. And of course, you can see here there's a little place out to the morgue and so on. And you want to do this, you see it said here, slope down, so you don't have all the stuff coming back into the institution. And you need to have some low-risk areas, obviously, for people who haven't got it, your laundry and other facilities. So this is a standard map plan of how Medicine Sans Frontières works with their management. And with all the spraying and stuff, you've got to dispose of the waste, something like 300 litres per bed per day, and it takes a long time to get all these infrastructures in place to deal with it. So you can imagine that you're getting deaths of the healthcare people as well as the patients. The HIV treatments are being lost, antenatal care is being lost, malaria treatments being compromised. The vaccination system for children is gone. We can predict a measles outbreak without too much difficulty, and there's a lot of trust in the healthcare system. So dealing with anything beyond the normal in these circumstances leads to a disaster. And you can see here's, this is an immunisation clinic just getting going again, which is really essential to try and keep some of these things at bay. That's if you're an African living in West Africa. What if you are a healthcare worker who are managing to be born in Germany, as this turned out to be? So this is a patient, this is published in the New England Journal of Medicine, 36-year-old chap. When he got into hospital in Hamburg, having been evacuated out of Africa, he was alert, he was oriented with mild abdominal pain. He has so little fluid in his system. When they looked for his big vein, the inferior vena cava was completely flat, as though there was no blood in it. But there's edema and fluid all leaked out into the tissues, particularly the bowel and the lymph nodes. But he was managing to breathe and do things quite well. He developed gram-negative sepsis, got bacteria that on top of this, indeed. And as they gave him lots of fluid, he then, all this started leaking out. So it came in around his heart, around his lungs. He developed respiratory failure. They gave him a bit too much juice at one stage, but he was managed without being intubated. And then he developed a severe encephalopathy. In other words, his brain wasn't working from day 6 to 14, and that slowly improved. He had a lot of hallucinations and delirium. This is just to show a little bit of data about what this happened to this chap. If you look along the top line, you see his temperature's running around the 40 mark for a bit. And you can see the most important thing is just to look down at the fluid measurements. You can see intravenous fluids. You can see on day 11 there, when he first, this is days of illness, and of course when he just got to Hamburg, they gave him 13 litres of intravenous fluid. I don't think I've ever given anyone 13 litres of intravenous fluid in a day. And if you go down a bit further, you can see there the diarrhoea, he had 8.5 litres of diarrhoea. So you can see getting the fluid balance right, what goes in and what comes out kind of balanced is a real mission. And of course, if you're working in a big tertiary centre, there's lots of clever tricks for doing that. You can see here over this time he's requiring 13, 11, 9, and gradually up to 13 again litres of fluid just to try and keep the right fluid in the intravascular space. And the diarrhoea volumes gradually go down. He's vomiting a bit as well. You can see his urine volumes there as well, and as he gets better the urine volumes go up. This shows the amount of virus in his blood. So the red line there shows the amount of virus, and you can see it stepping down after a few days out from his blood. And the other line shows the white cell count, which is a marker of bacterial infection. And when zooming up there, he got lots of antibiotics, and they managed to contain that. Now this has got some of the same information, but a bit of extra stuff, which is sort of interesting. You can see the red line there is the virus going down in his blood. But as you go across here to the yellow line, here we've got virus in his urine, which is persisting for a lot longer. And you can see the virus in his sweat. So you can imagine if you're in Africa and the patient's died and you're preparing them for the funeral, even if you're just dealing with the outside of the person, you're going to be exposed to virus in quite large amounts. And maybe even one virus is enough to infect someone. And slowly he made antibodies and he got better. Now, this, you can imagine that as we were watching this unfold from the infectious disease department's point of view, that we thought, oh my goodness, we're going to have to make sure we don't catch this if it turns up. And how do we manage how do we manage this? Now, this is a photograph of one of our infection control nurses, Ruth Barrett, and there's a lot of work went on trying to figure out how we could use our local resources to make sure we kept safe. And Ruth here is, so see, she's got some gloves on, and she's going to be taking all this stuff off. Now, the tricky bit is taking it off. Now, she's taking those gloves off there, and she's trying not to contaminate the outside. So there she goes inside the glove, running her fingers down there, and she's going to fold it back over the top without contaminating herself. Okay, she's just touching the inside of the glove, and then that gets disposed of in the appropriate place. Now you can see she's got a mark, and so she immediately then more alcohol rub on her hands to get rid of any that she might have got there by mistake. And now she's going to do the next manoeuvre. Oh yes, there we go. So she's just pulling undoing the gown from behind. And again, imagine if you're dealing with a patient who's got 8 litres of diarrhea a day and other things, you might be trying to dispose of that. There's a good chance you're going to splash yourself. So just touching the inside and not touching the outside at all as she goes down. Rolling it up outside in, and so then it can be disposed of in the appropriate place. Again, get the alcohol onto your hands, and then she's got a mask, and now you've just got to make sure you don't touch the outside of that thing. When you actually have it on, it's actually very easy to touch your hands onto the front of it. Dispose of that, and then hands behind, just get the little stretchy bits from the mask. Don't touch the front of it, and take it off, and then that gets disposed of in the normal way. Okay, so there's a lot of time and effort went into this, and Ruth led the team, and we all practiced. I can see Mark there, he practiced a fair bit. I hoped I was too old to have to go and see these patients. And then again, using the things. And of course, you've got to think about how you're going to dispose of all the stuff, how it's going to get incinerated, how it's going to be dealt with safely to get out of the hospital setting. And even just having the stuff on, I mean, I brought some of the stuff there so you could have a look, but if you've got a mask on and you've got this thing on here, you can imagine actually communication is pretty pathetic if you're inside a room where there's all this stuff around and you're trying to not contaminate yourself. So it really interferes with this sort of interaction with the patient. So at the moment, the treatment is basically supportive. You can see just by loading people with saline, you essentially save lots of lives. There are no approved treatments. There's lots of things that are in the pipeline. You've probably heard of the ZMapp, which has got 3 monoclonal antibodies against those little structures on the outside of the virus I showed you right at the beginning. And that's been shown to prevent deaths in macaques, even when started after clinical onset of disease. And some patients have received this. If the patient's recovered, then you can get antibodies from their blood, and maybe that will be helpful. So there's a way of using the patient who survived. There are lots of other fancy things that are being looked at to try and produce vaccines and other treatments. Now, one of the issues around this is that, and I'll talk about it more in just a minute or two, but one of the issues around this is that these things are not easy. The ZMapp is actually made in a tobacco plant, so it's been engineered to produce the right antibodies, and it can't be scaled up very easily. And not only that, there's a whole lot of intellectual property around it. There's also laws in the West African countries. Many of those countries had people doing clinical trials on HIV, which came in and were done, and then the companies left. And there wasn't provision made for people in that country, and so they got pretty fed up with people coming and doing stuff. So they passed laws saying you can't come and do this stuff unless you've got ongoing treatment for us. So one of the reasons I think why this stuff was only given to anyone in patients in the United States was because of all these issues around the laws and how you deal with it appropriately. So what are the basic lessons? Firstly, countries with weak healthcare systems and few basic public health infrastructures can't withstand sudden shocks. And when it happens, you get disasters on many of their levels. Preparedness, including high level of vigilance for reported cases and readiness to treat the first case as a national emergency. That's what happened in Nigeria. That's what that lady did. She said, I've got a case, I think I've got a case. The public health's coming down on you and you cannot move. The law's on my side and you've got to be prepared to push it through hard. There's no single intervention that's going to bring it under control. It's got to be the whole thing together. One goes, and I think one of the big issues has been keeping people isolated and not going out and visiting their granny or whatever it happens to be. And if that breaks down, then it's a problem. Community engagement is absolutely vital to manage to get contact tracing, early reporting, adherence to the protective measures and safe burials in place. So WHO has produced a roadmap of things that they would like to see put in place for 2015. But first of all, community resistance has got to be tackled, and their words are with the greatest urgency. Contact tracing is the weakest part of the response so far, at best 30%. I suspect that's an overestimate. That the response needs to be tailored to match the distinct needs at district and sub-district levels. So organising it just from big central places is no good when you've got lots of things going on in isolated places. And when there's a local flare-up, you need a rapid response team and go on and put it in place, what you need to do. They ended up with some really crazy situations where people were supposed to be quarantined and they didn't give them any food, they wouldn't let them out. They had a corpse in the room, and it just sort of created this horrible scenario for people who are supposedly being in quarantine. Decentralised strategy. I think there's a moral imperative to get the case fatality down. As I mentioned before, it's something like 25% in the evacuated people, it's 70-odd% in the good studies that have been done in Africa. And how do we do that? How do we respond? It's really essential to get the public health systems functioning again on a much more resilient footing. And we need to set up research, and there's two big things that are needed, vaccines and point-of-care testing. Now, both of those things can be done. It needs to be done not during an emergency. Emergency is not the time to do that stuff. What that means is commitment to develop these things at other times, because all the appropriate ethical and moral and legal obligations need to be fulfilled for them. Now, WHO, realising that this is actually a pretty pathetic effort in many ways, had an emergency meeting in January the 25th of this year, and their executive board unanimously said that with Ebola ending the current outbreak, strengthening global preparedness, ensuring WHO capacity to prepare for and respond to future large-scale outbreaks, emergencies and its consequences. And that was voted through unanimously. In fact, it took 4 days for them to reach that conclusion. And the big issue is around intellectual property. And there's various bits of the report which are quite interesting to read, but of course what's going on is people are trying to develop new stuff, and the question is, well, who owns it? And they're really saying, they're affirming the notion of intellectual property, but they're saying, look, they need to have some pooled funds to do this, and that but to do it, we've got to secure sustainable financing for health research and development on emerging and affected diseases. And it's unlikely to be funded just purely out of the private sector, and it will require a mixture of responses, and the intellectual property that's developed requires a lot of thinking through. They go on to say that we should have ongoing collaboration, and that they support delinkage of the cost of the new research and development. In other words, it's a fund of money that someone's got to put into the pot, and will get some clever people to develop these things that we need, and then they're owned by the public good. And but I think that is an ideal solution. However, I'm just a bit suspicious that that will be able to be achieved. not through lack of goodwill, but just the administrative hassle of how you do it and who's going to put their hand up is another matter. So, just as a quick summary, the outbreak in West Africa is a truly shocking human tragedy, and when you just sort of think about the things I've been describing, you realise just the depth of the events that have been going on there. There have been true heroines and heroes in the drama, and it will respond, just to the traditional things. We know how to control it. It's a matter of doing it hard enough and long enough with enough determination. But West Africa can't do it on its own, and it's going to need a lot of help to rebuild the infrastructure. All the research and treatments need to be developed, but that has to be done at times of when the epidemic is not in the middle of its sort of activities, and need to get these things done through an ethical manner. And so just let's not begrudge our foreign aid, which in many cases goes to less worthy ends than perhaps helping the public good.